PowerPoint presentation, you can do so at this time. Perfect, perfect. Well, at this time, I will welcome Margo Knefelkamp, who is a program manager at the Indiana Emergency Medical Services for Children. She's got a really great presentation for us today. And truly, without further ado, I'll go ahead and turn it over to you, Margo.
Good afternoon. Thank you, Allie. Again, this is Margo Knefelkamp. I've been the program manager for Indiana Emergency Medical Services for Children for the last 4 years. 59 states and U.S. territories have an EMSC program. For Indiana, it is funneled through the IU School of Emergency Medicine with an agreement of the Indiana Department of Homeland Security EMS division. Dr. Elizabeth Weinstein is the principal investigator of the grant. She is a duly trained emergency medicine physician and works splits her time between the Eskenazi ED and the Riley Children's Hospital Emergency Department, and is also the chief of pediatrics for the IU School of Emergency Medicine. Indianapolis EMS offers in-kind support of the grant, and 15% of my time is with the MESH Coalition focusing on pediatric disaster preparedness. So we'll go ahead and dive right in here. EMSC programs, it's a federally funded program through the Health Resources and Services Administration to reduce pediatric morbidity and mortality as a result of serious injury and illness. As you all know, our EMS and trauma systems developed during the 60s and 70s. These systems were developed primarily with an eye towards adult injury and illness. It became apparent in the late 70s and early 80s that huge health disparities in our ability to care for children were developing. EMSC grew out of the need to address these disparities in our care capabilities. The first funding was established back in 1985, and since that time, the program has had profound growth. It now encompasses several different arms with the same fundamental mission. The oldest among these are the state partnership programs, or EMSC programs. These programs work to develop and support infrastructure and systems improvement in the care for children at the state and federal level. Indiana has had continuous funding for this since 2009. We do have a robust advisory board and a FAN rep. She's our Family Advocate Network representative who provides the patient-parent perspective. We have 9 performance measures. The first 3 are EMS-based, and the remaining measures are regarding facility recognition and the permanency of EMSC in your state. EMSC integrates pediatric preparedness and skills, equipment, resources, and planning into our existing infrastructures. Back in 2006, the Institute of Medicine released the report, Emergency Care for Children, Growing Pains, noting that we are still woefully underprepared to care for children. Unfortunately, although children make up 27% of all visits to the ED, many hospitals and EMS agencies are not well prepared to handle these patients. Children account for approximately 25 million ED visits annually. That's roughly 25% of all ED visits. 83% are seen in community hospitals, and the vast majority of these centers see fewer than 15 kids a day. The fewer kids you see, the more ready you need to be. In 2001, the American College of Emergency Physicians and the American Academy of Pediatrics sent out this joint policy statement, Guidelines for Care of Children in the Emergency Department. In 2007, 6 years later, national experts in pediatric emergency medicine conducted a national survey of over 5,000 emergency departments. Only 30% of hospitals responded, and the results of the survey were grim. As an example, fewer than 6% of the responding hospitals nationwide carried all of the equipment recommended to care for children. In 2009, guidelines were updated, and in 2013, the Pediatric Readiness Project was launched. The guidelines consist of 7 domains: administration and coordination, physician, nurses, and other healthcare providers, quality improvement, patient safety, policies, procedures, and protocols, support services, and equipment, supplies, and medications. Outgrew the Pediatric Readiness Project. This is a coordinated effort to benchmark and improve pediatric care for children nationally. This was a combined effort from Emergency Nurse Association, the American College of Emergency Physicians, the American Academy of Pediatrics, and EMSC programs. The 2013 survey was launched. This was coordinated through all EMSC programs. It was a web-based assessment. Emergency department personnel would log on and complete the assessment. It was in compliance with those 2009 guidelines I mentioned. And in this assessment, 5,107 hospitals responded. That's an 83% response rate. Here in Indiana, we had an 87.6 response rate. It was on a weighted scale from 0 to 100, and this will be repeated. It was initially to be repeated this year from June to September, but because of our current situation with the COVID-19 pandemic, it's been postponed. We do not have an update yet as to when that will occur, but I'll make sure to get that information out to everyone. On the assessment, there are 189 items, so it's a fairly large assessment. 82 of those are scored for pediatric readiness. A hospital could have a perfect score of 100, and there are 6 major sections similar to the 7 domains I listed previously in their points. When we look at Indiana, how did we do? Well, we scored 67 out of 100. 106 hospitals in Indiana responded out of the 121 assessed for a response rate of 87.6%. The national average was 69. So think about that on a scale of 100. Our median hospital score was 67. A few years after this, a group called PCOM, Pediatric Community Outreach Mobile Education, this is through Riley Children's Hospital, sampled hospitals and went in and asked those same questions and asked for those hospitals to verify that, yes, you do have this in place. And then we found out that our scores is actually inflated. When they did the sample and went back and asked those questions, hospitals said that they had it when they truly didn't. So the big secret is, there is no big secret. We are not ready for kids. So out of that came facility recognition. Facility recognition, we know, is not a foreign thing. We have recognition for stroke centers, neonatal ICUs, trauma, heart centers. So pediatric facility recognition is also not a new thing. Programs have been in place in states like California and Illinois for decades. Taking a look at this slide, the red stars, there's 11 of them, have programs, pediatric facility recognition programs already in place. The blue or slight blue states, including Indiana, have been a part of this national collaborative that started in July 2016 and ended in December of 2017. There's a wide variation in the number of levels with a high degree of agreement to that criteria based on that joint policy statement. For example, Tennessee, Delaware, and Alaska have 4 tiers. Arizona and Illinois have 3. West Virginia, New Jersey, and Ohio have a single level. Taking a peek at Illinois' program, they have a 3-tiered process in place and have since 1998. This is in partnership with the Illinois Department of Public Health. Out of 185 hospitals, 110 participate at the 3 levels. The Pediatric Critical Care Center, there are 10 in the state of Illinois. 87 emergency departments approved for pediatrics and 13 standby emergency departments approved for pediatrics. Indiana does have hospitals that are recognized by Illinois' EMSC program. We have Union Hospital in Terre Haute. We have Deaconess Hospital in Evansville, both campuses, and also Ascension St. Vincent, Evansville. Indiana's process, IEMSC established working groups who started meeting monthly. I have a breakdown of those who met monthly on the next slide. We followed the National Collaborative, who went through the guidelines and developed the criteria for Indiana. Held a consensus conference in November of 2017 in partnership with the Indiana State Department of Health. Asked if this looked feasible for Indiana to attendees from healthcare systems and critical access hospitals throughout the state. IEMSC then went back and revised the guidelines, and applications were made available November of 2018 to begin piloting hospitals for recognition. Indiana's facility work group consisted of the Indiana State Department of Health, both trauma and injury prevention, as well as hospital preparedness division, the Indiana Rural Health Association, the Indiana Hospital Association, the Indiana chapter of the American College of Emergency Physicians, the Indiana chapter of the American Academy of Pediatrics, Indianapolis Patient Safety Coalition, the pediatric chair of the Emergency Nurse Association here in Indiana, pediatric intensivists, pediatric hospitalists, and pediatric emergency medicine physicians. This was an 18-month process. So out of this process, we developed Indiana's 2-tier process. Hospitals can apply to become pediatric ready, which is the minimal preparedness to treat, stabilize, and transfer as needed, and pediatric advance, which is pediatric ready with additional resources to care for children. And we do have a critical care tier under consideration at this time. We are still in the pilot phase. 17 Indiana hospital emergency departments have requested the application. 3 hospitals have returned the completed application, and just before everything started shutting down back on February 28th, we were able to conduct our 2 hospitals in the same day for the Insight person survey. And we are looking forward to scheduling the 3rd hospital when they are available to move forward. It is organized in the 7 domains. It's a voluntary program, and recertification will occur every 3 years. The hospitals that have already been a part of Illinois' EMSC program will be grandfathered in at a later date. The 7 domains: administration and coordination. Does your emergency department have a pediatric emergency care coordinator? This can be a nurse, advanced practice provider, or a physician. Do they have administrative time to promote pediatric specific activities, including but not limited to education quality improvement initiatives and policy development, and should spend a significant clinical time in the ED where they serve as the pediatric emergency care coordinator, or what we call PEC? Domain 2, health provider standards. These are physicians, nurses, and other healthcare providers working in the ED. What is their training and continuing education in the care of pediatric patients? Domain number 3, quality improvement. Pediatric specific indications included in the emergency department quality improvement plans for patient safety. Pediatric patients weighed and recorded in kilograms, a full set of vitals, age-appropriate pain scale, a process in place for identifying abnormal vital signs, a process for safe medication storage, prescribing, and delivery is established and include the use of pre-calculated weight, length, age-based dosing guidelines for infants, children, and adolescents, infection control practices, access to 24/7 interpreter services, timely reporting, tracking, and evaluation of patient safety events. Domain 5, policies, procedures, and protocols, a validated pediatric triage tool, interfacility, pediatric-specific transfer guidelines and agreements, disaster preparedness plans. Hospitals shall have disaster preparedness plan that integrates the pediatric-specific needs. Special care should be made available to include procedures for reunification and decontamination, and then policies and procedures addressing the death of a child in the emergency department. Domain 6, support services such as medical imaging capabilities and protocols addressed age or weight appropriate dose reductions for children, laboratory. And then domain 7, pediatric equipment, supplies, and medications are appropriate for children of all ages and sizes, easily accessible, clearly labeled, and locally organized. Logically organized, excuse me. The site verification process. The hospital expresses interest by contacting IEMSC and will receive an application packet via email. This includes the welcome letter, instructions for submission, facility recognition criteria for both pediatric ready and pediatric advanced, both applications, a completion guide, a site checklist, and credentialing worksheets for the physician and other personnel that you have working in your emergency department, advanced practice providers, nurses, respiratory therapists, and EMS providers. Hospital completes the application and submits application back to IEMSC. The application is reviewed by 2 team members. Written feedback, including gaps within 90 days of submission. If meets criteria, we'll schedule a site visit. The site survey process will provide an overview. IEMSC requests an opening conference to include introductions and who we recommend to attend. EMSC will then provide an overview of the EMSC program. We ask for a SWOT presentation by hospital staff, an emergency department tour, review of documents and manuals, and then conclude with an exit meeting. This process takes approximately 4 hours. Formal written feedback is then provided to the hospital within 60 days, and then the hospital has 90 days to address any deficiencies. I also wanted to briefly mention the ASPR Pediatric Surge Annex requirement that each healthcare coalition right now is working on and wrapping up currently. And if you look at the last part of this slide, members planning for pediatric medical emergencies and foster relationships and initiatives with emergency departments that are able to stabilize and or manage pediatric medical emergencies. And that very last part is facility recognition, pediatric facility recognition, making sure that your emergency department is prepared for pediatrics. Part of that pediatric surge annex is having those pediatric specific interfacility agreements. A defined process for the initiation of transfer, including the roles and responsibilities of the referring hospital and receiving hospital. A process for selecting the appropriate care facility, a process for selecting the appropriately staffed transport service to match the patient's acuity level. If you have specific questions regarding interfacility transfer agreements, I do have a toolkit that is a great resource. Part of the interfacility transfer agreements are also guidelines. In order to assure the children receive optimal care, timely transfer to a specialty care center is essential. Such transfers are better coordinated through the presence of interfacility transfer agreements and guidelines. This is hospital to hospital, including out of state or territory, that outline procedural and administrative policies for transferring critically ill patients to facilities. that provide specialty pediatric care. These are more of the guidelines that are recommended: a plan for patient transfer, including informed consent, plan for transfer of the patient medical record, a copy of the signed transport consent, personal belongings of patient, and then to have directions to the referring institution to provide the family. Guidelines versus agreements. Agreements establish the relationship for transfer between facilities in writing. Hospital to hospital negotiate this. This is the formal arrangement for consultation and transport of a pediatric patient to that higher level care facility, and it's focused more on roles and responsibilities. This here is a picture of Dr. Kate Remick. She is the hospital lead for our National Resource Center called EMSC, Innovation and Improvement Center. It's located at Baylor and Texas Children's Hospital. We know emergency departments vary in their level of readiness to care for pediatric emergencies. This was a retrospective cohort study in Florida, Iowa, Massachusetts, Nebraska, and New York, focusing on patients aged 0 to 18 years with critical illness defined as requiring intensive care, admission, or experiencing death during a counter. They used ED and inpatient administrative data from the Agency for Healthcare Research and Quality's Healthcare Cost and Utilization Project, linked to hospital-specific data from the 2013 National Pediatric Readiness Project. They studied 20,483 critically ill children presenting to 426 hospitals. The median weighted pediatric readiness score was 74.8. Unadjusted in-hospital mortality decreased with increasing readiness score. Adjusting for age, chronic complex conditions, and severity of illness, presentation to a hospital in the highest readiness quartile was associated with decreased odds of in-hospital mortality. The research found that children who presented to an ED with lower pediatric readiness scores had the increased risk-adjusted mortality with critical illness. Concluding that presentation to hospitals with a high pediatric readiness score is associated with decreased mortality. Efforts to increase ED readiness for pediatric emergencies may improve patient outcomes. As mentioned, the National Pediatric Readiness Project that was to start in June has been postponed, and again, no official launch date at this time. On the EMSC Innovation and Improvement, this is the National Resource Center, more information about the project, all the work that occurred previously in 2013, and the reassessment of hospital emergency departments. We'll make sure that we provide additional details once those are released. Here's another part of the EMSC website. Indiana EMSC does have a website. It's currently under revision, and we are in our final stages of editing the site, and we think that we'll hopefully have it ready and available the 1st of June. The American College of Emergency Physicians, the American Academy of Pediatrics, and the Emergency Nurse Association released an ED checklist. This was made available at the end of February. And emergency departments can go ahead and work through this 4-page checklist to see what your hospital already has. You can do that gap analysis so that if you do have questions or want to go ahead and apply to become a PEDS Ready or Pediatric Advanced Emergency Department, then you know if you have that in place or what you need to work on towards attaining that. And if you have specific questions or need our toolkit, please don't hesitate to reach out to us. And I also wanted to point out that there are various toolkits available for you on the National EMSC Resource Center. If you're looking on the right-hand side of your screen there, various ones. If you don't have those interfacility transfer agreements in place and need help working on that, if you need help on working on your disaster plan and what that looks like for your emergency department, there are resources available to you as well. So in summary, Indiana Pediatric Facility Recognition Program is available to you. You can apply, you can reach out to myself, just give me an email. We do know based on research that pediatric readiness is associated with increased survival. We discussed the National Pediatric Readiness Assessment. It is postponed for now, but there is that checklist available to you. Additional resources, Indiana EMSC produces a monthly newsletter and a quarterly pediatric emergency care coordinator newsletter. We are in the process right now of identifying a pediatric emergency care coordinator at every EMS agency. And the goal is for that pediatric emergency care coordinator to work with the pediatric emergency care coordinator in the emergency department to work on quality improvement initiatives. The website, indianaemsc.org, as well as pediatricreadiness.org for the National Pediatric Readiness Project, a couple of scenarios for disaster improvement, and then also there's the link for the interfacility transport toolkit. If you have any questions, also I would like to ask the group if you know of the person who should be receiving if you know of the person in your emergency department who should be receiving notices from Indiana EMSC, or the one that is to complete the survey, because we know that leadership has probably changed since 2013 in all of your hospitals, or a majority or some. So if you want to reach out to me, I've included my email address as well as the website.
Thank you so much, Margo. I'm looking here in the Q&A and in the chat. It doesn't look like we have any open questions, but it was extremely informative. I know I learned a lot. Autumn, you can go ahead and stop the recording, and we'll leave the link open for just a little bit longer. If anybody has any questions or anything they'd like to add for Margo, now is the time.